We'll move to our last presentation here from Dr. Pilishvili.
Good afternoon, and thank you, Sarah, for such a thorough presentation. It's a very tough act to follow for two reasons, because of how great the presentation was and also the amount of data that she presented. I'm hoping I can keep your attention for another 30 minutes or so. So I think to continue the discussion and put it into a little bit of a framework of what we're talking about, because grade does, I think somebody made a comment here that the grade has a little bit of a narrow focus, and it does take away from like what are the conclusions really. So I wanted to start by reminding the committee where we started. And in October, we actually discussed that there are multiple factors that need to be taken into account when we are considering a policy change. And evidence review is a big component of it. And first and foremost, we need to demonstrate that the available evidence support the change. And in October, we presented this extensive review of evidence that focused on all types of study designs. We included randomized controlled trials, we included observational studies, we included ecological studies, and we addressed each individual outcome, including the ones that GRADE did not consider, because a GRADE framework limits the review to outcomes that are only critical. But all this evidence was presented in October. And then at the suggestion of this committee, we were asked to assess the quality of this evidence, and that's what we did. And Sarah presented a very good review of the very long and laborious GRADE process that the work group worked on. And to conclude again what the GRADE showed, and specifically the GRADE conclusions, I think earlier on Sarah showed this step one where we assessed the evidence supporting each of these schedules. And the GRADE conclusion was, and I think that was a consensus of the work group, that we do have a strong quality evidence supporting each individual schedule when we compare it to no vaccine. So compared to no vaccine, each schedule is supported by this strong evidence and a category A recommendation. And then we went into comparing those schedules to each other, and we were limited to only studies that have made those direct comparisons within the study. So we were hence limited to only the 3 outcomes that were included in a GRADE for this particular question. And because of the limited evidence with direct comparisons, the evidence was of lower quality, and the consensus within the GRADE framework of the work group was that the GRADE supports the category B recommendation. However, we're not making a policy conclusions yet. In addition, there are some key issues that are not covered by GRADE review. I already mentioned that the outcomes were limited because of the rankings, and we included only critical outcomes. So, for example, data on nasopharyngeal carriage was not included in our review, and I'll visit the rationale why probably we should revisit it and consider that data, as well as observational studies. According to the GRADE guidelines, if there's sufficient data available through RCTs, we are setting it to include only RCTs, and yet we're ignoring this vast amount of post-licensure data that has been accruing over the years from countries that have used this various schedule. And that was overlooked by GRADE, and I will try to highlight some of the key studies in my presentation. And then again, someone mentioned that the GRADE does not really conclude anything, and other than the type of evidence and the category of the recommendation, and some of the main conclusions are missing. So maybe we can revisit again the conclusions that largely remain unchanged by outcome as we presented in October. I'll present the update on the analysis of the PCV13 breakthrough cases and failures. This is again data we presented in October, but some updated numbers are available, so we'll just review them briefly. And in terms of other considerations, and I showed that slide with bubbles, the work group has not discussed each and individual set of considerations, but did raise some important concerns in terms of programmatic and implementation considerations that we should take into account. And for that, we looked into the data on PCV13 coverage using National Immunization Survey. And we also reviewed the literature on parental acceptance of vaccines and factors that influence the refusals and delays in vaccination. And lastly, I'll present the conclusions of the work group, and these are conclusions that the work group was prepared to present so far, as far as and also the next steps as work group views as to what we can do for this policy question next. So in terms of the evidence not accounted for grade, I'll review some of the key observational studies that look at the impact of PCV on invasive disease, and also revisit the outcome of nasopharyngeal carriage and rationale why we should probably look into it. 3 case control studies and 3 studies using indirect cohort method evaluating effectiveness of various PCV7 schedules are presented here. And as you can see, the effectiveness estimates are organized by schedule. And for the 2+0 schedule, which some of the studies were able to evaluate, the effectiveness estimates ranged from 70% to 99%. For a 2+1 schedule, there were 2 studies that were able to evaluate the effectiveness for this schedule, and the effectiveness estimates ranged from 98 to 100%. And also from 3+0 and 3+1 studies, we had more studies that looked at the effectiveness of these schedules. One thing to keep in mind when we look at these estimates and are tempted to make the cross-study comparisons is that none of these studies were powered to make the comparisons, especially when comparing two values that show high effectiveness. In other words, none of these studies were powered to detect the difference between the 99% effectiveness and 100% effectiveness. In addition, and I guess if we consider the differences in settings and countries and methodologies, still the overall picture is, and we can conclude that all of these schedules are quite effective in reducing invasive disease. So the slide here highlights some of the surveillance data showing the population-level impact of PCV introduction in 10 countries, 11 populations. And the graphs are organized by year post-PCV introduction. So year 1 through year 3 post-introduction, we're trying to control by time since the vaccine introduction in this analysis, as well as the schedule and a country. So the impact is measured in terms of rate ratios. Rate ratios are presented on y-axis, and rate ratios compare the incidence post-vaccine introduction to pre-vaccine baseline. And again, I think what is striking from, I'm not going to go into numbers and show the numbers for each of the graphs, but the similarities in terms of the magnitude of the impact observed between the schedules and between the countries, even though the surveillance methodologies differ, and even though the countries and settings differ, coverage may be different, as well as the extent of the catch-up program may be different. Overall, with every schedule, we are seeing these dramatic reductions in IPD, vaccine-type IPD among children less than 5 years of age. And another trend that is also noticeable, that with more years post-vaccine introduction, the reductions are also greater in all settings with all schedules presented here. A very relevant to the objective of this session, as an example that I'm presenting on this graph, it's PCV impact data on vaccine type IPD, which comes from Canada. The data I'm presenting is from the IPD surveillance in Calgary. And in Calgary, PCV7 was introduced as a 4-dose program in 2000. believe it's 2002. And PCV13 replaced the PCV7 in 2010. The results that I'm showing here are for PCV7 serotype IPD. And as you can see, as soon as the PCV7 was introduced, shortly within a year after that, dramatic reductions in the burden of vaccine-type disease were observed in the vaccine target age group, children 0 to 23 months, as well as in all older children and adults. And then PCV13 replaced the PCV7 on a 2+1 schedule. And I'm only presenting PCV7 type disease, but still highlighting the fact that the PCV7 type disease continued to decline, and the rates remained at 1 or less than 1 case per 100,000 for all age groups that are presented here. Rates in PCV13 type IPD are presented on this graph. Following the 7-valent vaccine introduction on the 3+1, there were increases seen in these additional serotypes that are included in the 13-valent vaccine and not the 7-valent. And those increases were most prominent in the vaccine target age group of children 0 to 23 months. But when the PCV13 was introduced on a 2+1 schedule, they show almost immediate reduction in PCV13 type disease shortly following the PCV13 introduction, and these trends continued through 2013. And to summarize what we can conclude based on the GRADE review, based on the review that was presented in October, in terms of invasive disease, evidence from RCTs and observational studies suggests that each schedule, 3+1, 3+0, and 2+1, is highly effective in preventing IPD. None of these studies were designed to compare any of the 3-dose schedules to a 4-dose schedule head-to-head. And also we have to be mindful that the direct comparisons across studies are not meaningful. And I mentioned that earlier. They do not take into account the differences in populations and methodology, and also they're not powered to detect a difference between two very highly effective schedules. I'm not presenting any additional data for pneumonia, but again, to summarize the conclusions as far as the effect of these schedules on the pneumonia outcome, evidence from RCTs and observational studies shows that each of these schedules prevents pneumonia. One observational study, which Sarah presented in her presentation, which had these head-to-head comparisons of the 3-dose schedule to a 4-dose schedule, showed that the 3-dose primary series is better than a 2-dose primary series before booster dose, early in the immunization program. However, no statistically significant differences were observed post-booster or for later birth cohorts examined. And so the conclusion is that the schedule with 4 doses may be more beneficent against pneumonia, but early post-vaccine introduction. However, later in the vaccine introduction, that those differences might simply go away. I mentioned that we should revisit the endpoint, the outcome of nasopharyngeal carriage. And so why is nasopharyngeal colonization data are important to consider? NP colonization is necessary before infection can occur. And reductions in vaccine serotype colonization, which are observed in studies, and we've shared these studies with you in October, mean that those serotypes are less available to cause the disease before the disease even occurs. And also the reductions in carriage from this use of different schedules, they provide more direct evidence of reduced transmission, which is expected with each schedule, in addition to the evidence that we observe through the indirect or herd impact studies on IPD. There are slides with the studies that we've highlighted in October that are included in your handouts, but I will not go through them again. However, I will summarize again for the outcome of nasopharyngeal carriage what the evidence shows. Available studies show that all schedules reduce acquisition of colonization with vaccine serotypes compared with no PCV. 3-dose primary may be better than 2-dose primary before booster dose at 1 to 7 months following the series. However, no differences are observed at 12 months of age before booster, and also no differences are observed after the booster dose receipt. In addition, we presented the results of a study that it was a carriage survey conducted in Atlanta that looked at the impact of the PCV13 introduction on the carriage of vaccine serotypes. And what the data shows is that post-PCV13 introduction, this US carriage data suggests that PCV7 types are very rare. In fact, in that study, only one serotype, one PCV7 serotype, which is 19A, was isolated. And PCV13 type carriage is also decreasing. So to conclude, the overall evidence review, which includes the grade review and the review that we have shared with the committee before, 3-dose PCV schedules are effective against IPD, pneumonia, and otitis media. Immunogenicity and carriage studies show that 3+1 schedule may be better than 2+1 before booster. However, no differences are observed post-booster for most serotypes. There are strong direct and indirect herd effects observed in countries using the 3-dose PCV schedules. And now that we've talked about conclusions by outcome, we've talked about the grade, step 1, step 2, and all the numbers that have been thrown at you. I think as we did in October, I would like to ask the committee to perhaps step back and look at the big picture and what these results and what these studies mean in the context of the US PCV13 program. We are observing these differences in antibody response between schedules, and they may lead to the differences in carriage and potentially lead to the differences in disease. However, these differences may not be meaningful in a setting of a strong national immunization program we have for PCV and already observed large direct and indirect benefits from the PCV use. PCV7 serotypes are very rare in the US, and you saw it in an earlier presentation that the impact of PCV7 has virtually eliminated PCV7 serotypes as causes of IPD, and also rates of PCV13 type IPD are also declining. Among not only children that are receiving the vaccine, but also among all age groups. And the population-level impact of 3-dose PCV schedules, both direct and indirect, is similar in the countries that use this 2+1 schedule and a 3+0 schedule is very similar to the one that we observe in the US. This is data also that I showed in October, but I will reiterate again that the overall rates of invasive disease in children less than 2 years of age are 14.6 cases per 100,000. And of these, meningitis rates of meningitis are 1.2 per cases per 100,000. But if we look at the PCV13 serotypes, the rates of PCV13 type IPD are 2.2 cases per 100,000 and 0.3 cases per 100,000 for meningitis. In addition, if we look at the distribution of cases that are occurring among children less than 2 years of age, more than a third of the cases are among children less than 2 months of age, so that is before they're even eligible to receive the first dose. And in that window of risk, which immunogenicity studies and the carriage studies points to, which is the 6 to 11 month window before the booster is given, we only have seen one case of PCV13 type disease reported in the 2 years of the data. In addition, we looked again to an updated analysis of the breakthrough infections reported to active bacterial core surveillance, and that's for the 3 years 2010 through 2013. And from the 275 cases of IPD that received 1 or more doses of PCV13 type IPD cases, there were only 44, and these are breakthrough infections. In other words, they received 1 or more doses of PCV13, and they were of serotype included in a PCV13. Full 4-dose PCV13 schedule, or 3+1, was given only to 5 of these. So we have true vaccine failures, only 5 true vaccine failures reported in the 3 years that are included, almost 3 years that are included in the surveillance. We also examined the vaccination status of breakthrough cases by serotype and PCV13 schedule. There were only 4 serotypes that are associated with breakthrough infections, and those are serotypes 3, 7F, 19A, and 19F. So from the 44 breakthrough cases reported to ABCs, the majority were serotype 19A, 33 or 74%, and the majority of these were receiving schedules other than the ones listed here. So there were schedules other than 2+1, 3+0, and 3+1, and the majority were occurring after a single dose of PCV13 was given. And then I also reported at the bottom that I think there was a question from the committee last time that if any of them were meningitis cases, and there were, from the 44 breakthrough infections, there were 4 meningitis cases, 2 serotype 19A, 1 type 3, and 7F, and there were no deaths among the breakthrough infections that were reported. And again, to go back to the overall picture of all the considerations that have to be taken place before we make a decision on a policy change, we are not going to discuss each an individual one, but there were a couple that were already addressed by either grade or the presentations in October. Sarah mentioned that economic analysis was presented to the committee in October, and it was also considered as a part of the grade process, although one caveat was a cost-effectiveness analysis that it does not consider that the vaccine price might be adjusted. So that's a big assumption of the economic analysis. Safety data was also presented, and it was part of the grade review, and Sarah mentioned that there's maybe additional analysis that is forthcoming that will be presented to this committee. And lastly, the work group discussed the programmatic considerations, and the work group felt that it was important that we evaluate the performance of the vaccine program to deliver high coverage at each time point in the immunization schedule, and evaluate adherence to the currently recommended schedule, as well as delays in timing of each dose and effects on completion of the recommended schedule from these delays. And also to evaluate the potential for non-adherence to introduce disparities in coverage. And for these first 2 questions, we looked into National Immunization Survey data, and I'm going to present some of the data to you. And also we reviewed the published studies on parental acceptance of the recommended vaccination schedules and factors that contribute to delays and refusals of one or more recommended vaccines. The graph on this slide presents cumulative PCV uptake curves for children included in a 2012 National Immunization Survey. Each line represents a PCV dose number and percent uptake for each PCV dose on y-axis and age and month on the x-axis. So 84% of children surveyed received their first dose on time. So the first dose is presented with a blue line, and 84% is at the timing where the first dose is recommended. And we really applied a strict criteria here of exactly the schedule of at 2, 4, and 6 months of age to look at the timeliness of the dose administration. So 84 received the first dose in a timely fashion, 73% received the second dose on time, and 63% received the third dose on time. The booster dose was received within the recommended window among 63% of those surveyed. And in addition, if we look at this 84% mark, that's by 12 months of age. So by 12 months of age, 84% of children completed their primary series and therefore would have still been eligible to receive a 4th dose as a booster because of the timing of the completion of the primary series. Next, we wanted to evaluate how timeliness of doses in the primary series affects the uptake for the rest of the recommended schedules. So the graphs that are presented here are the same uptake curves as on the previous slide, but one thing to keep in mind is, and it's very confusing, it took me also a while to digest this data, that the denominators are different. In the previous graph, the denominators were all children surveyed, whereas here we stratified, and we're looking at among children who received dose 1 of PCV on time on the left graph, and among children who received the dose 1 of PCV late. And again, on time and late, we're again applying that strict definition. That's before 3 months of age would be on time, and at 3 months or later would be late. And another thing is to keep in mind, because I'm not presenting the percentages out of the total children surveyed, if you look at this graph, I know that there's a pointer somewhere. Oh. It's backwards. So 84% received their dose 1 on time, meaning that when we talk about those that did not receive it on time, it's the remaining part of the curve. So those that did not receive on time actually represent a small percentage of children surveyed and small percentage out of the total population. So in this next series of couple of slides, I want you to keep that in a perspective, because the percentages are out of a different population. So among children who received the dose 1 of PCV on time, 86% received dose 2 on time, 74% received dose 3 on time, and 94% completed the primary series by 12 months of age and therefore were eligible to receive a 4th dose as a booster. And 73% of children who received the dose 1 on time, they received a booster within the recommended window. Among children who received the dose 1 late, and that's the right side of the graph, you can see the differences. Less than 10% received dose 2 and dose 3 on time, which is obviously because they delayed their first dose. But as far as the completion of the primary series before 12 months of age, 47% of these kids only completed this series by 12 months of age, and therefore would have been eligible to receive a booster in their 4th dose as a booster in their 2nd year of life. And 29% of these children with delay in the first dose received the booster, 4th dose booster within the recommended window. This is a very similar graph, but here we are stratifying it on the timeliness of the 2nd dose. So the left side is among children who received dose 2 on time, and the right side among children who received the dose 2 late. And again, please keep the first graph in mind. That shows that very small percentage of children are actually on the right side of the graph. And from the children who received dose 2 on time, 85% of those received dose 3 on time, and 98% completed the series by 12 months of age and therefore were eligible to receive a 4th dose booster. And on the right side, we see the same picture where the delay in a 2nd dose results that less than 10% of children received dose 3 on time, and only 59% of these children complete the series by 12 months of age and therefore are eligible to receive a booster. We also reviewed PCV13 coverage among children currently receiving a total of 3 doses. So this was a data that we actually presented in October to the committee. And following the data presentation, I received the comments and suggestions that we should do this analysis, which suggests that we didn't probably communicate it very well. So the table turned into a graph. So let's hope we're able to communicate it better. So here we're looking at, again, a very small percentage of children that are surveyed as part of the national immunization surveys. 10% of children are the ones that receive a total of 3 doses based on 2012 survey. And from this, you can see the ones on the left. So what we're showing with the graph is the timing of the dose 3 administration. So that's age at dose 3 is presented on the x-axis, and on the y-axis we present the percentage of children, but that's out of those that received a total of 3 doses. So in other words, the left side of the left bar here presents 22 or 23%. So these are the 23% of children that received dose 3 at 6 months. In other words, this is a 3+0 schedule, and they didn't proceed to receive the fourth dose. And similar, if we look at the right, the last bar here, these are the children that received their third dose at or after 13 months of age, so this is similar to a 2+1 schedule. So all these bars that are closer to the left resemble more a 3+0 schedule, whereas the ones to the right resemble more a 2+1 schedule. But again, this is a very small percentage of the population, but what it shows us that 3-dose schedules, yes, there are some children that receive a total of 3-dose schedules, and the timing of this third dose can be anywhere between the 6 to 13 months of age, and we can have a wide range of 3+0s and 2+1 within this group. We also reviewed coverage by schedule and poverty status. So the data in a second and third column are coverage estimates, percent vaccinated and 95% confidence interval for children receiving at least 3 doses before age 12 by poverty status. So this is 3+0 plus, I guess it's 3+0 schedules and more. And the next two columns are estimates for children receiving at least 2 doses before 12 months of age and 1 dose in the second year of life. So more like 2+1 or more. And the last two columns estimates are for 3+1 schedule. So what we are showing here is that overall, for each schedule, the coverage goes down as the poverty level increases. And that is true for each of these schedules. If we look at within each poverty strata, the coverage is the lowest for the 3+1 schedule and higher for these 3-dose schedules, more 3+0 and 2+1. In terms of the statistical differences, the significant differences were not observed across the schedules within each poverty strata, but overall, in terms of differences between the first schedule and a second schedule, so it's 84% coverage versus 85%. These two were significantly different. And also the overall trend is for within each poverty strata, as well as overall, a 3+1 schedule has the lowest coverage. So to summarize what this all coverage data means, what we can conclude is that the vast majority of children receive PCV doses in a primary series on time. The majority of children complete PCV primary series by 11 months of age and therefore are still eligible for a fourth booster dose in their second year of life. Among children for whom either dose 1 or dose 2 are delayed, a smaller proportion are eligible for and complete the 4-dose schedule. Small proportion receive a total of 3 doses, and it's difficult to identify based on this data and based on a small proportion of children receiving a 3-dose schedule, which 3-dose schedule would be preferred if we were to make that recommendation. And also the coverage decreases with increasing poverty level for all schedules, and within each poverty strata, coverage is lowest for the 3+1 schedule. So if I still have your attention, there is another set of data that I'm presenting, and this is studies that we reviewed on, these are published studies on parental acceptance of the vaccines and factors that are associated with parental delay or refusal to vaccinate. As part of the 2009 NIS survey, parents of children 24 to 35 months old were interviewed to evaluate the association between parents' belief about vaccinations and their decision to delay or refuse vaccines for their children. So the results of the survey show that around 26% of parents delayed 1 or more recommended vaccine doses, 8% refused, and almost 6% both delayed and refused. Delays and refusals were associated with parental beliefs that children receive too many vaccines can overwhelm a child's immune system, and that vaccines have serious side effects. Delays and refusals were more likely among parents with higher socioeconomic status, and among children with lower coverage for all 10 recommended vaccines that were assessed. According to the results of the 2010 Health Style Survey, from the top concerns reported by parents or guardians of children less than 6 years of age, 38% reported concern that it is too painful for children to receive so many shots. 36% reported that their child is receiving too many shots, and 34% believed that overall children get too many vaccines in their first year of life. This was a cross-sectional internet-based survey of a nationally representative sample of parents of children 6 months to 6 years of age that evaluated alternative vaccination schedule preferences among parents. From this survey, more than 1 of 10 parents of young children currently use an alternative vaccination schedule. Non-Black race and not having a regular provider were associated with increased odds of alternative schedules. A large proportion of parents currently following the recommended schedule also were determined to be so-called at risk for switching to an alternative schedule. 28% believed that delaying vaccine doses was safer than the schedule they used, and 22% disagreed that the best schedule to follow is the one that was recommended by experts. The table here is from the same study that I presented on the previous slide, and it shows proportions of parents who refused delayed vaccines or used prolonged dosing intervals. Among parents who reported refusing some vaccines, 31% refused PCV. Among parents who reported delaying some vaccines, 10% delayed PCV to older age than recommended. And among parents who prolonged dosing intervals for some vaccines, 33% did so for PCV. There are additional studies that we reviewed that I included them again in your handouts, but they pretty much support the findings of the studies that I presented. And so to summarize what we learned by reviewing the literature on parental acceptance of vaccines is that the majority of parents surveyed adhere to and do not have concerns about the recommended schedule. Parent decisions do lead to vaccine delays, and that ranges in studies from 13 to 25%. And also to refusals, 6 to 10% surveyed for 1 or more recommended vaccine doses. Parents who delay and refuse vaccines doses are more likely to have concerns about vaccine safety or multiple injections at each visit. Parents who follow recommended schedules also report exhibiting doubts and have considered alternative schedules or refusing the vaccine doses in the future. And as far as the relevance for the question that we are considering today, it's based on this published literature. It's very hard. It's unclear whether removing a PCV dose and removing it at 6 months of age, or whether it's 12 to 15 months of age, will actually help reduce these refusals or delays of other recommended vaccines. But the data does show that the multiple injections and some of the concerns that parents have with multiple injections at each visit is something that is reported when parents are being surveyed. And lastly, I wanted to present the conclusions of the work group. So these are the conclusions that the work group was prepared to make today as of now. The grade review suggests that 3-dose schedules are likely equivalent to a 4-dose schedule. Evidence from countries using 3-dose schedules is reassuring. Acceptable schedule in a setting of a mature immunization program and strong herd effects may not need to be the same as that chosen at the time of the licensure. A 3-dose PCV13 schedule for infants is likely appropriate to maintain already observed benefits from 13 years of PCV use in the US. And at this point, work group is not prepared to make any specific policy recommendation. And the work group believes that including a 3-dose PCV13 schedule for routine use among infants requires careful consideration of implementation issues. And there are further discussions that are needed to define the groups that should be excluded from this potential policy change, and also evaluate the potential impact of non-adherence to this new recommended schedule on disease and on the coverage. Also, so there will be discussions at the that will take place on work group on the groups to be excluded from the potential policy change, and also rationale for this exclusion. There have been preliminary discussions with the experts that work in populations with American Indian and Alaska Native populations, and they presented some of the early data showing why we should consider excluding this group if we were to recommend a 3-dose schedule for routine use. And that's based on the historically higher rates of disease observed in these populations. And disparity is still observed, although most of the disparity that is now observed is due to non-vaccine serotypes. And also, there's a history of ACIP recommendations being specific to Alaska Native and American Indian populations. However, there are still discussions that need to be taken place to define specifically which populations would be excluded if we were to recommend a 3-dose schedule for routine use. In addition, a careful discussion is needed to identify the underlying medical conditions that would be indications for a 4-dose policy, for dose schedule. And that will be, and if we were to again proceed with a 3-dose schedule for the routine use in infants, and that will be also rationale will be based on historical or existing disparity in disease incidence, known lower PCV effectiveness in certain populations, or reduced immune response compared to the one that is observed in healthy children. And the work group believes that there's got to be a very clear list of indications that will for whom the 4-dose schedule will remain if we were to proceed with a 3-dose schedule. And also a careful consideration should be given to implementation issues related to the timing of the diagnosis of these conditions in relation to the schedule selection. And lastly, the work group will give further consideration to the following policy options, and these are listed in no particular order of preference. One option would be to recommend 2+1 schedule for routine use, and 3+1 schedule will remain for high-risk groups, and these are to be defined. Option 2 would be to recommend a 3+0 schedule for routine use and 3+1 for high-risk groups. Option 3 would be to recommend the 3-dose schedule, and that will be either 2+1 or 3+0 for routine use, and leave 3+1 schedule recommended at provider discretion for healthy infants. And also 3+1 would remain for high-risk groups as a recommended schedule. Option 4 is 3+1 will remain for routine use, and the 3-dose schedules 2+1 or 3+0 will be optional for healthy infants, and 3+1 will remain for high-risk children. And option 5 would be status quo and no change to policy. So these are the policy options that will be discussed by the work group. I will conclude with that and leave the questions for discussion that Dr. Bennett raised earlier. And with Dr. Tempte's permission, open for questions?
Yes, we are open for questions. Dr. Karen.
So I guess Rich introduced the term tour de force. I think it applies to you too, Tamara. Thank you so much. I have a question and maybe a couple of comments. So my first question, when you had showed the population level impact across all serotypes for introduction of various 3-dose schedules in a number of countries, I appreciate that. I was wondering if there are any serotype differences or any signals that stand out for particular serotypes to suggest that one schedule might be better than another, or do the data, when you look at individual serotypes, pretty much mirror what you see here for the composite?
Right, so there are some differences in populations in terms of the serotype distribution, but the data that presented was focusing on PCV7 serotypes, and I believe, and I think subject matter experts will correct me if I'm wrong, but I believe that within the PCV7 serotypes, there is less variation in terms of the distribution of those serotypes across the populations that we presented data for. There is more variation for additional serotypes, or serotype 1 and 5, that are included in a PCV13, but not in a PCV7. There's obviously, ABCs actually, in the US, we have looked at the data by serotype, and there are certain populations they have the power to look at individual serotypes. We could probably review some of the data, but for most of these studies, I don't think they have power to really dissect and look at individual serotype data.
And then my next question really has to do with the schedules and sort of programmatic considerations and choices between the schedules. And I was wondering if you could go, at least on my handout, it's slide 21. I know the numbers may have changed a little bit, but
what is it titled?
21, at least in the handout. Oh, sorry, it was the one, the age distribution of the IPD cases.
Okay, so that would be slide 18. The one before, yeah, there.
So, so I was looking at this slide, and I think it would be great to have data from additional years to sort of to increase the numbers and see if the distributions are the same. I presume they probably are. But I was looking at this, and then I was looking at your sort of 12-month and up dose, which whether kids got back, it was sort of that brown line in many of your graphs, whether kids got vaccine on time or whether kids didn't get vaccine on time, it always seemed to me that there was a bit of a problem with that fourth dose. I mean, it was somewhere between 70%, 50%, something like that. And so I look at this graph and I get a little bit concerned about a 2+1 schedule, because if you start delaying that, I mean, I don't think you'll get that quote unquote fourth dose any sooner if it's a third dose, if it's a 2+1 schedule. And if you start delaying it too much, there is invasive disease that goes on in that 12 to 18 month age range. And I just am wondering if the data we already have are telling us something about a 2+1 versus a 3+0 schedule.
Dr. Dusky?
I'd like to open up the time machine and go back and look at the HPV and the quagmire, and I've used that word once before here, regarding permissive recommendations. Let me speak against option 3. Let me speak against option 4, as it will open a quagmire, and I foresee a potential for scattered coverage across the country. The data is either strong enough to recommend it, or the data is not strong enough to recommend it, or it's strong enough to recommend it, or recommend it for certain groups.
I appreciate your comment, and there were several on the work group that actually shared your concerns.
I'm going to ask a follow-up question to that, actually to Dr. Freihofer. How good are our internists in terms of adhering to pneumococcal recommendations for high-risk patients?
A work in progress.
Thank you. I have Dr. Warshawski.
Thank you very much for all the presentations. They're very interesting. I just had one comment and then one question. So the comment is just that, as mentioned before, in Canada, we do a 2+1 schedule in most provinces. And one of the things that we have done is to try to really encourage that the +1, the booster, be at 12 months. It's not in a range of 12 to 15. It's at 12 months, if that's what the province adopted. My question, though, is first on slide 23 on those failures. There, do you know for the 2+0 and 3+0 when the failure occurred, like how old the kid was when they failed, and whether that would have been prevented by a booster at 12 months?
Yeah, I actually have a slide on the follow-up time. It's one of the backup slides. Could you pull up the outline? Oh, will I be able to drive it? Or it was too fast for me, I'm sorry. No, a little lower. No, I actually do have a slide, but I think what we need to keep in mind is we looked at the duration of the interval between the last dose and the occurrence of disease, and it's a pretty wide range, and it's for each of these schedules. It can be soon after the vaccine was given, and it can be also like a delayed. But because of the case numbers are so low, we could not really make any conclusions based on like, is it worse after 2+0 or is it worse after 3+0, because of we have said just five based on 5 cases. But if we can pull it up, yeah, there it is. So yeah, as you can see, exactly for that comparison of post 2 and post 3, if we look at the point estimate and the ranges, I don't think we don't see any difference here. So this is average days and range for number of cases that are for each of the schedules following the last dose administered.
If I could just make a follow-up comment. I've heard this kind of data presented before when Quebec did it first. They were the first to go to a 2+1, and what they talked about is the number of cases that would potentially have been failed in that kind of schedule. So it might be helpful to actually say that of the 2+0, how many would have failed in a 2+1, so that you know the true number of failures in that scenario, if you know what I'm saying. So not just the average, but the actual number of cases that might have failed under a 2+0.
I see. Okay. So stratify those 5 cases by. Thank you.
Dr. Bikini.
I also had a concern that with the groups being excluded for potential policy change, we're essentially going to end up creating 3 different pneumococcal policy recommendations. We have for healthy children with no increased risk, high-risk children, and then this other group of patients that would maintain the 3-dose primary schedule and the booster as opposed to a 2 and 1 or 3 and 0. And so I think it's going to add confusion, and it's going to be really hard to define those groups effectively for the practitioner. And then there are also subgroups like, what about kids who go to daycare who are under a year of age, and others that in the past had higher risk for pneumococcal invasive disease that sort of disappeared under the current vaccine regimen. So I think we need to pay attention to those groups and then wonder how, if you build that add so many patients, whether it's really an effective way to go.
Right. Thank you.
I have Dr. Herman.
Well, I was going to say kind of what you said, but also just to follow on Ruth's comment, again, looking at the 3.3+0 and the 2+1, just, this was a lot of data to absorb, but just scanning through the various studies, it looked like 2+1 had better efficacy in most studies than 3+0, unless that's just scanning through it quickly. So, I mean, I don't know what the answer is. I'm just saying there's a lot of ways to slice this.
I have Dr. Vasquez next.
With option 3 and option 4, when you say 3 doses are just as good, but there's also the option of 4, if we make such recommendations, what would happen with coverage by insurance companies?
You remember what happened with the HPV? It was permissive. People could choose. Plans chose. You remember Ghostbusters when they made the big marshmallow man? That's what would happen.
Dr. Shugat.
Yeah, we've had clarification about the Affordable Care Act implications of permissive recommendations. And essentially, the Affordable Care Act requires insurers to cover vaccines that are recommended by the ACIP, and it's all about the footnotes of the schedule. So it's what's in the schedule and what's in the footnotes of the schedule. And if it's in the footnotes of the schedule, a year after, in the first calendar year, that's a year after the vote, the insurers have to cover that story when it is provided by an in-network provider. So the the new era means that footnotes are where the action is.
I have Dr. Middleman and the Dr. Harrison.
Hi, Middleman Sam. Adolescents aren't really in this too much, but I'm just a little bit confused. I'm wondering if we have any data. We're talking a lot about addressing parents who are admittedly the minority of parents who get these immunizations late and may refuse. And I would argue that education is a better approach to that. But having said that, there are some data about that. But do we have any data about what the potential message of is in decreasing the number of doses and making it appear as though this vaccine may be expendable or perhaps not important for children, and the effects that that may have on immunization? That's very concerning to me.
Yeah, I'm not aware of any of the data, but if anyone can comment.
Yeah, this is, there are many different subsets of parents and attitudes, and it's important not to overgeneralize. And I think Tamar did a really nice job of summarizing a lot of literature. People who vaccinate their children regularly express questions and concerns about the number of shots at a single visit. Some of the people who want to vaccinate want to not have so many shots at the same visit. And people do express questions of, are all of those shots really needed? So I think the theoretical implications of a policy change are very difficult to predict, but there's certainly a stewardship of the immunization schedule that the ACIP holds to carefully review the risks, benefits, value, need for each dose that you're recommending. So I think it's not really to say this group of parents will drop out or that group of parents will question everything we're doing, but just to say that the point of this review is that there's a lot of evidence about ways to give the pneumococcal vaccine, and it's one of the vaccines that it is given at the time with many other vaccines.
Dr. Harrison.
To Dr. Harriman's point about the level of protection for 3+0, I'm actually fairly troubled by the immunogenicity data of 3+0. I mean, the GMC ratios are like 0.2 to 0.6 compared to the 3+1. I was wondering if the working group, what the thoughts were about that. And I really question the durability, therefore, of
Dr. Kemp? Dr. Kemp?
I just had two comments about the programmatic issues. I think we have plenty of evidence or about the issue of whether to give different options. We have plenty of evidence that primary care physicians and pediatricians specifically cannot and do not identify high-risk children. We had plenty of evidence with that with the 6 to 23-month-old group. So that's problematic. I think going on the issue that was raised about what the message will be giving, it's also a little bit of concern I have, not about dropping a dose, but about putting it out there as an option. Because I can see as a primary care physician doing a lot of debating about other vaccines being, maybe we could drop that booster as well. So I think really careful. I guess I'm worried about having either optional or high risk, multiple possibilities on both those levels.
Dr. Kemp, was that called?
Yeah, I just want to explain where I'm at, because I'm not on the work group, but I want the work group to know where I'm at so that they can convince me or not next time around. Because right now I'm not that we should make a change. I think that one of the parts about the schedule we have to consider is how confusing it is for providers as well as patients. And there's something synchronous about having 2, 4, 6, and then afterwards it goes with other vaccines. It fits in nicely to the schedule. Everybody gets the same recommendation. When you start parceling out based on risk and options and things, it just confuses the schedule more. And I think that's a major problem. So for me to go, I would go with either a 3-dose schedule or a 4-dose schedule, nothing in between. And to convince me to go to a 3-dose schedule, you got to convince me that it's equal to a 4-dose. And I don't see that in the evidence. Great evidence for a 3 versus 4 dose is low-level evidence. So that's where I'm at.
I'd like to just pick up one of those points too that I think made by Dr. Dusky and several others, that the other part is how do you put it into one of the immunization information systems that I rely on all the time, that if it's made optional, we do a notoriously bad job of capturing high-risk conditions put in there to inform us what to do. And so again, especially, we see this over and over again with the high-risk conditions for Hep B in adults, for pneumococcal in adults, for HPV in those optional groups. You know, we do a terrible job with that. So I would concur with the sentiment that we would like to see something fixed and not variable. And then I think Doug's comments on the grade presentation, which was very good, are very worthwhile to think about. Dr. Bennett.
So I just want to comment on a couple of things. First of all, I think the laborious grade work that we did really convinced me that the schedules are equal in efficacy, and I'm unhappy we didn't convince you of that. But I think the other thing that's really important is that it is our obligation morally to review any recommendations we make, and if it means taking back a dose and it looks ugly and it's complicated, that's too bad, but it's the right thing to do. And we are in a very different situation now than when we started giving this vaccine. We now have very little disease circulating related to the serotypes that are in the vaccine. And as a result, I think we really have to look at this very, very closely and think very long and hard about, is it too complicated? Is it, going to convince people not to give vaccines, et cetera, et cetera? I think those are all concerns, and I think the work group, and the reason we haven't brought you a request for a vote, is that I think the work group views all of those concerns as very serious. And I think the work group is really trying to work its way through this and think about all the possible unintended consequences of changing this schedule and how it could be communicated in a way that would help people to understand that we're really just trying to do the right thing for these kids and parents. And it doesn't undermine this vaccine at all. It simply says this vaccine has done such a great job, we might be able to give you one dose. And I think that's a message we can convey. And I think we can convey it with confidence.
Dr. Brady.
Yeah, I'd just like to say that we had this presentation at the American Academy of Pediatrics Committee on Infectious Disease, and we were pretty much like Doug. First of all, I think that the evidence, so the 3+0 has 3 studies, and it may be methodologic because the time between them was not appropriate, but that's the only data we have. It's not convincing that 3+0 works. The comparison of 3+1 to 2+1 is low evidence. The other situation is, if you look back when we used to use risk factors for influenza vaccine in children, we did a really bad job. And right now we're going to say that children who are at high risk need 3+1 and other ones can use another schedule. And what's going to happen is we're going to end up with a real problem because it's not going to happen the way that the recommendations are stated. And those children at risk are going to get lost and they're going to get too few doses and we're going to have more disease. And I really do think that, again, when we start piling up all the groups, and I do have to think that we have to remember that African American children had a much higher rate of disease, that when you do this, you're going to come out with the majority are going to end up needing to get it, but we're going to have this kind of crazy recommendation. And the average pediatrician who's trying to get their electronic health record to give them prompts about which vaccines they're supposed to get, they won't be able to do it properly. I just think that the status quo currently provides the best protection and creates the opportunity to minimize the chances that we'll put more children at risk.
Ms. Pellegrini.
I wanted to follow up on one of Dr. Bennett's comments here, and I think that there is a potentially compelling argument that could be made to say that we did a great job with this vaccine. Cases of disease have gone down and maybe we dose, but I think if we're going to consider that, what we have to be prepared to do is explain why that isn't the case for any other vaccine schedule. The last naturally occurring case of polio was in 1979, but we still give polio to every. So this I think goes to some of the basic education issues, basic education problems that we have.
I have Dr. Lair.
A bunch of comments. One for Doug specifically, HIB already has sometimes 2, sometimes 3 for the primary series. It's already a variation. We have variations mixed into the schedule. The work group asked, what more information do we need to make this decision? And I'm not sure I need more information. I think it comes back actually to beliefs. And there's a bunch of different perspectives as we approach this topic. And some people are talking, if it ain't broke, don't fix it. And some people are talking, well, if we don't need something for the resources or the injections or the pain, let's not do it if it's not necessary. Personally, I believe that if we go to a different schedule, there are going to be more cases, but that might be appropriate given the amount of resources we're putting into it. And there's one last point I'd like to make is I have a large number of vaccine hesitant parents in my group, in my practice. I think that the CDC and the ACIP consciously saying that we don't need all the vaccines anymore, that we're doing such a good job, is actually sending a valuable message to them that it's being a really well thought out process, that we're not just adding vaccines again and again and again, but we take them away when they're not necessary anymore. So I would say that's a very valuable signal to send.
Dr. Harrison. And then Dr. Reingold.
For me, as an epidemiologist, I look at the data from the countries, including countries comparable to the United States, that either have gone with a 3-dose schedule in the first place or have moved to a 3-dose schedule where effectively the impact they've seen is identical to the impact we've seen, with obviously 25% less in the way of costs. And so from my perspective, I think an interesting question would be, I don't know the coverage data in these other countries. Maybe they do a better job in terms of their coverage than we do, and maybe that would be worth looking at. But it seems to me that we have pretty convincing evidence from a variety of comparable countries you can accomplish the same thing with a 3-dose schedule.
Dr. Moore.
Thanks, Kelly Moore with the Association of Immunization Managers. I want to throw in my hat with those who express operational concerns, although I don't yet know for me what the right answer is in terms of decisions. I think it's incumbent upon us to avoid unintended consequences by carefully thinking through the operational implications of a split schedule where high-risk children still need more vaccine than regular healthy children, because we know, as others have said, that risk-based recommendations don't get implemented effectively. Do we want to introduce that uncertainty? If we are going to, we just need to work out the registries, the EHRs, and other operational things from a programmatic standpoint to make sure that we don't make the same mistakes by introducing a risk group into this consideration that wasn't there as a special consideration before.
Dr. Sawyer.
I'd like to go back to the long ago comments about delayed last dose, whether it's 3rd or 4th dose, in the context of Dr. Reingold's comment. I do think we do need to look at the coverage rates in these other countries that have had success. My feeling is they do a better job at a prompter or tighter interval at around the recommended age in delivering the vaccine. And I, as the work group knows, am very concerned about a 2+1 turning into either a 1+1 or a 2+0 in a significant number of children, as shown by the dark line in the graphs that Tamara showed.
And we have someone up at the microphone.
Thank you. My name is Rebecca Coyle, and I'm with the American Immunization Registry Association. Excuse me. I think this issue actually highlights a very big issue for those of us that work in the electronic health record and information system arena. As you start considering to add or separate schedules or add high-risk conditions, it becomes very difficult for an electronic system to take that information and translate it into an appropriate clinical decision support for the clinician or whoever's making that decision. So I really want to just highlight the importance of the decisions that you make here and how cumbersome that can be on the technology side to implement as well. And thank you for my comments.
Thank you. Another comment up here?
Yes, please go
Just want to restate we had stated earlier the October meeting, and which is the FDA's position that from our standpoint, we are very concerned about the possibility of a recommendation for different dosage that's different from what's in the label, because in the absence of data presented by the manufacturer for a change in the regimen in the label, we will not be making any changes in the package insert. And we consider that a different regimen recommendation would, for the first time in a vaccine for routine immunization, would present a lot of ambiguity for and confusion for the healthcare provider as well as for parents and insurers and vaccine manufacturers.
And back here at the microphone.
Yes, this is Luis Jodar, Pfizer Vaccines Medical. Well, first of all, thank you very much, Tamara, and everybody for just that tour de force of data. I don't know how to start. I mean, I have a number of technical concerns with the grade, but I think what I'd like to start is just with an overall comment that I think it is important for us to reflect. When we say that we have a mature PCV program, I think that is a little bit ambivalent. What does it mean, a mature? We have a mature PCV7 program. And I think we all should remember that what we are judging here is to change on a schedule of PCV13, and those are 6 different serotypes. And in all the world, PCV13 has only been introduced 3 years ago. So to extrapolate the conclusions that we are seeing after 14 years to PCV7 into PCV13, I think it's a little bit risky. And I think we are very encouraged with the effectiveness that Matt has presented today. But admittedly, it's the first year that we are seeing serotype-specific effectiveness data. And I think in 2 weeks in ISPPD, we are starting to see emerging data from those countries that have introduced PCV13 in 2+1 serotype-specific effectiveness. And you may see variability, serotype-specific variability. So my question is, or I think my overall concern is whether we consider PCV13 really a mature program only after 3 years and only after we are learning about, are starting to learn about serotype-specific effectiveness. And I don't think anybody here believes that all serotypes are created equal. Serotype 3 or serotype 19A or serotype 7F. My other question, I think, about grade is that we are also thinking about that all conjugate vaccines are created equal. So when you give your evidence about IPD efficacy, for instance, for a 2+1, the efficacy is for a 10-valent vaccine with 3 different carrier proteins, and that it's not even licensed in the United States. Or when we talk about the 3+0 evidence, we're talking about PCV9, which was discontinued. It's not PCV13. Or we're talking about PCV11, which was discontinued for development for pneumonia. So what I'm just trying to say is that I mean, we are going to make a change on PCV13, which is a completely different vaccine, based on evidence on other vaccines. And my last comment is on immunogenicity. It has been talked a lot, and I was surprised that all the grade in immunogenicity here was not done with PCV13. And you have published a study in JAMA in 2013 comparing different schedules with PCV13 at 2, 4, 6, 3, 2, 3, 4, 2, 4, and 3 and 5. And I think it's true. Somebody mentioned here about the intervals. Yes, it's true that intervals are different. 2, 4, if for some serotypes, like 6B and 23F, are worse than 3, 5. And those are worse than 3 doses. Consistently, 6B and 23F have lower percentage of individuals reaching the 0.35 microgram per ml than 3 doses. So I think if you looked at that 2013, you will see that, and I think that would have been probably a better evidence, since what we are discussing is PCV13 here. Thank you very much.
One of the additional pieces of evidence that might be useful for the committee in general might be more specific information on the national programs that went from a 4-dose schedule to a 3-dose schedule, when that happened, if there was any resurgence of disease in those countries, and so on. I see Nancy shaking her head, but I think if we had the benefit of seeing some of that information, that'd be very, very helpful for us. So I think we're still open for any suggestions of any additional information or evidence or considerations. Dr. Jenkins.
I know that this is a series of presentations, and I don't remember. I wasn't here in October. And so was there, I'm back to Dr. Brady's comment about African American children, but mostly just knowing about other disparate populations. You did mention the issues with poor children and their them being less frequently completing the series. So I would like to know when we look at this further, whether there are some disparities in the vulnerability of children based on either ethnic diversity or poverty status in a way. Because I applaud what we're doing here, which is going to look at the resources we have and determine whether we're using them optimally. But I also think we have the goal of making sure that we don't put any other children at greater risk as a result of those kinds of decisions. So I just would like to have a little bit more information on the diversity issue to make sure that we're not, potentially creating disparities.
Dr. Duchin.
Thank you. This is a good discussion for me to hear. I'm part of the pneumococcal working group, and I see a lot of value in evaluating a potentially more economical immunization schedule. But of course, that doesn't want to come at a cost that would outweigh its benefits. So it's very good to try and, continue to hear the ACIP and the liaisons and others help us weigh the potential risks and benefits. My specific comment now is about the American Academy of Pediatrics, and because, as we heard this morning in our discussion of influenza vaccine, how important it is for the ACIP and the American Academy of Pediatrics to be so-called synchronized or harmonized. I would really encourage the American Academy to look carefully at this and come back to us with an official American Academy of Pediatrics opinion about this issue, so that we can take that into consideration as this moves forward. I wouldn't want to get in the same position where we are with the flu, where we're very advanced on one end and the other is still sort of deliberating. So if we can sort of synchronize our thinking about this problem, it might help if we get to when we get to the point where we're going to make a decision. Thank you.
Thank you. Other comments here? This is a very rich and I think a needed discussion here. Dr. Schuchat.
Yeah, just since the committee and the working group are going to continue to deliberate, I wanted to give you one more piece of some food for thought. Currently we have Healthy People 2020 targets of 90% for 4-dose coverage of pneumococcal conjugate vaccine. As many of you know, Dr. Frieden is very keen to measure impact and achieve impact and make sure that we're accelerating achievement of impact. He asked me, he noted our various coverage levels and saw that we were kind of around 80% coverage of 4 doses of pneumococcal conjugate vaccine and asked me how much additional impact could we have if we could get to that 90% level. And I said 0. So I think one thing for the committee to kind of think about is, what are programs doing? What are providers doing that have HEDIS measures or performance-based pay in trying to achieve a 4-dose completion? Is there something that ought to be changed around what we're aiming for, in addition to the question of whether the recommendations themselves ought to change?
I just pulled up the new 2014 childhood immunization schedule. And as we all go back to our homes, I would suggest everyone read the 3 pages of footnotes, 3 pages, particularly the pneumococcal section on that. It's extremely complicated, to see if there are other ways that potentially we can simplify things. The idea to make recommendations is to have them implemented. We all need to consider that.
I think there's been some very good discussion here. I think one of the bits of feedback that I've heard fairly clearly, but correct me if I'm wrong, but it would be very difficult to slice and dice a recommendation and have a recommendation where we have different schedules for different, and we're not talking very small groups of high-risk children, such as those with immunocompromising conditions. We're talking about fairly large demographic groups that certainly could be problematic for implementation. And especially those are groups that may not be captured on the information system. So I think in general, going forward, and this is not only for the pneumococcal working group, but also I think going back to the COID, is I think we're, as a group, willing to kind of scrap the idea of having different recommendations for different relatively large groups of people. Am I summarizing that correctly? What I'm saying is we don't want to have a recommendation of 2+1 for most kids, but if you're African American or if you're Native American, we need a 3+1 schedule. And all these things that, because of risk factors, make it very, very hard to implement efficiently.
So let me respond to that. The issue is, I mean, we definitely hear what everyone is saying about the complexity. We also definitely hear what everyone is saying about permissive, make a choice, whatever, that's too complicated. However, I think it's fair to say that if we were to reduce a dose, we would have to have different recommendations for certain high-risk groups. I don't think it has to be super complicated. I think that's, and I obviously have more faith in my pediatricians than, but I think, to say that we cannot have a high-risk group would be to say that we cannot reduce the dose for anyone. And if you're thinking about children, you're giving an awful lot, potentially, you're giving an awful lot of extra shots for healthy kids that just to be sure that the not so healthy kids get enough. So I think we have to be very careful about exactly. I mean, I don't think we can prescribe that at the moment.
But I don't want to interject too much, but I think once we start looking at the fact that simply by living in poverty, there's a risk factor for not completing your schedule, which it's different, but that also introduces potential for, with a dose reduction, it introduces the possibility of not completing that new schedule and dropping, instead of a 2+1 down to the 1+1. And it's just in terms of those consequences. And unfortunately, we live in a country where there's a lot of children living under the poverty line. So
I guess I'd just distinguish between immunologic concerns with a reduced dose schedule and, programmatic, practical issues. And we do take both of them very seriously in the work group. So, but I would put those in two different pots as we're making decisions.
So have we provided, oh, Dr. Harrison.
Well, then let me ask my question again. Were there any concerns in the working group about the immunogenicity data for the 3+0?
I don't remember, and Tamara, correct me if I'm wrong, I don't remember there being, tremendous concerns about immunogenicity. I think that from a programmatic perspective, some of the working group members seem to think that maybe a 3+0 would be a little bit easier to implement than a 2+1. But from an immunogenicity standpoint, I don't think there were great concerns that, oh no, 3+0 is terrible and 2+1 is substantially better. Tamara, do you want to?
Yes, to address Dr. Harrison's comment is we did look at the timing of the assessment of the antibody response, and some of the studies that we included were following the most recent dose. So the comparisons that Sarah presented as part of the grade were antibody response was assessed following the third dose in the primary series in the 3+0, and then following a booster dose in the 3+1. And we know that's not a fair comparison because of the boosting effect that you get with the delay in the last dose administration. But at the same time, we looked at a subset of studies that did look at the comparison at the 13 month of age for both of them. And the differences were smaller in terms of the number of serotypes that showed the differences. So in other words, if you wait longer, the antibody response declines in all groups, and then I guess that boosting effect and immediate effect of the boosting goes away. We don't know what that means in terms of clinical protection, but in terms of the antibody response, the differences go away with the time post dose.
Dr. Kemp.
So I'm on the pneumococcal working group, and I think there is, not everyone is completely sanguine because unfortunately the data we have is not perfect. So, yes, there was that graph showing that between 6 months, your booster 3+1 looks better, but that was old data. And then there was one study sort of saying, well, maybe that's better now because, of baseline, but that's pretty limited data. So I can't say as a working group member I'm totally sanguine about that.
Other discussion? Have we provided the work group with some fertile grounds for thought? Now,
Actually, yes, and the work group is very appreciative of the time that everyone has been putting into looking at these data and talking with us about this and discussing the implications of any possible change. So we are very grateful and very appreciative.
I think in terms of the time, I just want to mention for everybody in here that Dr. Coyne Beasley, Dr. Walter Williams, and Dr. Kristen Sheedy have all volunteered not to be presenting on adult immunization this afternoon in the interest of this wonderful discussion. So we are not going to try and keep you here real late tonight. Also, I had talked to Frankie Milley and have you come up for an additional comment there.
Hi, I am Frankie Milley, and I am the founder and national director of Meningitis Angels, which represents hundreds of families across this country. Many of them are pneumococcal families. You've met a couple of them over the last months. I will tell you one, and by the way, I vote for option 5. I'm often reminded as I look at the angels within our network, one of my favorite but yet most painful photos of all of our families is a young mother who held her very young toddler in her arms as they took her off of life support because she didn't get that 4th dose of Prevnar. This is awful. This is just awful. I made 4 points. Normally I don't come with notes, but I didn't want to forget it. I think that we've seen in the past when we've requested or required or recommended a certain amount of dosage. If you recommend 3, they're going to get 2. If you recommend 4, they're probably going to get 3. We see that with HPV, the hepatitis vaccines, all of them. We see that. We know that that happens. Also, I think when you start changing the schedules again, I think, and especially when you're downgrading the requirements or the recommendations, I think that says to those parents, you know, well, maybe we can downgrade some of the rest of them. Maybe we don't need this one for this and that for that. I realize that we need to look and be very careful what we put into our children. But again, as I said in October, if it ain't broke, don't fix it. I also believe that I've worked really hard around this country for daycare entry requirements, which require pneumococcal vaccine. I think if you start changing those recommendations, you need to think and consider, is that going to change all of those daycare requirements that we've worked for years on? Are we going to have to go back to those policymakers, to those states where we've worked really hard to save those kids and get those kids immunized, especially in states where we do have a high minority rate? I know in Texas, when we worked with our legislators, one of the things that I said to them when we were trying to get daycare entry is we are depriving the most at-risk children in this state of this vaccine, and that was our African American population and our American Indian population. Without strong recommendations, it doesn't get paid for. We all know that. So I think we just have to be very, very careful. I work with a lot of families out there, a lot of parents. I have a lot of young parents that call me all the time. A lot of them I know, a lot of them I don't know. And I tell them that you guys work very, very, very hard to make sure that the recommendations you put out are the best and the safest for their children. But you know what? I am begging you guys. I was really hoping that this would just be gone, but I can see that it's not. We have so many immunization issues and problems and diseases and things that we need to be looking at and deciding how we should recommend those vaccines, but I don't think Prevnar is one of them. I think we need to move forward, not backwards. And you've met several of my kids. I don't want my group to grow anymore with pneumococcal kids. And I'm afraid with the change, that's exactly what's going to happen. But I want to tell you that I appreciate the work that all of you guys do. I mean, you volunteer, you have to have a passion for what you do, and I appreciate it. Thank you.
Thank you very much.